Hi everyone, welcome to my presentation. I did it on a patient at Bozeman Health Outpatient Pediatrics, my first rotation. She is 17 and she had a birthday while I was with her. She identifies as bisexual. She lives with her mom and five siblings, one from the same father who she does not have a relationship with due to history of abuse. And then the other kids were from a stepfather who recently moved out. So there was some turmoil in the household between stepfather and mom, leading to some more challenges. Her primary conditions are schizoaffective disorder, anxiety, and PTSD. She did receive that PTSD diagnosis while I was working with her during an inpatient rehab stay, and that sort of brought the schizoaffective disorder diagnosis into question. And then she also suspected a dyspraxia diagnosis, which I will get to. Secondary trauma, overwhelm. She had a lot of social anxiety, and then her inability to focus in school. So the reason for seeking services, she had been seeing my CI before I met her, but when I started seeing her, it was right after an inpatient psychiatric stay. And her personal challenges is that she really wanted to be better in social situations, and then in classroom engagement, she had a really hard time navigating. Like, she felt like she was always going to run into people and things, and then she also had a really hard time focusing in the classroom due to sensory overload. And then her schizoaffective diagnosis was based on one of her self-soothing behaviors, is that she would walk around in circles, and she would just do that for hours on end. And then she also heard voices sometimes. Successes is that she did have some interest. She liked drawing, anime, writing, even though sometimes she got really fatigued and felt like her coordination wasn't completely contributive to being able to perform the occupation. She did have some healthy friendships. And then barrier in her home environment is just kind of the chaos of all the symptoms and the recent turmoil between mom and stepdad. Back to that history of abuse from her biological father. Supporting factors, she did self-soothe, and even though they were not always the most adaptive, it was good that she had that self-awareness to do so. She was really motivated and intelligent and did have a supportive social network. She really liked her friends that she spent a lot of time with on the phone. They were inhibited by some socioeconomic status. It seemed like she was really challenged to get the right nutrition. She wasn't eating properly. She wasn't sleeping properly. She was challenged by her coordination deficits, sensory sensitivities, and then her trauma. And then some of those performance patterns that I touched on is she liked drawing, really interested in science. She did do the coping mechanism of walking around in circles. And then inhibitive, she was not eating or sleeping. So just going through this from the OP, her desired performance was with social engagement, education, and driving with community mobility. For prevention, having better navigation skills and coordination for safety. For health and wellness, nutrition, and also sleep. For quality of life, just more ability to participate in daily activities such as education and social participation. Being able to navigate in school and the community without that anxiety of running into people and things, and then that role competence of being a sister, a daughter, a peer, and a friend. So based on the frame of reference of cognitive behavioral sensory integration as well as role acquisition to participate more fully, I use the evaluations of the BOT2, so assessing her motor proficiency, and that did show a deficit for her age in motor planning and coordination. We did do the CAWA model, some primitive reflex testing, and then the overall evaluation is very similar to the occupational profile in that it is a narrative, interactive approach to learn about the patient and her caregiver and the home environment. So touching on all these in the intervention plan with social participation, we did lead a group. There was another patient that came on the caseload at the same time, so had some similar challenges. So we actually put them together, which was really great for them to practice engaging and conversating. and then just working together. They did some cooking, made some art, and then we did the Kawa model with them together. For community mobility, I took her on a walk and let her navigate, practicing sort of that ability to make decisions and that proprioceptive input. We often challenged her with tasks of navigating around the clinic independently, so obtaining objects, setting up rooms, just going in room to room. And then we created a list of activities together of community engagement that she wanted to participate in. For coordination, I kind of gave her graded vestibular and proprioceptive input opportunities. She had a really low threshold for these, so it was very gentle to start. Some sensory integration, identified her preferred smells, and created a tool for her to keep with her when she needed. We did some life skills and preparatory tasks. So creating that list of community engagement opportunities, we sent an email that was drafted to her mom and suggested making alerts with time and days to facilitate that, as well as setting an alert to give her medications on time, which is something that she was challenged with. And then we created a daily schedule for her with self-care routines as well as a checklist that she could follow. We did some advocacy, recommending that alarm for her mom so she could take her meds on time, and then talked about ways for her to advocate for herself with educators to cope in school. Trauma-informed care, so we always made sure that she was okay with doing the group. She wasn't always comfortable doing it every week, but we started with that. We also led with individual check-ins. And then I also co-treated with an SLP, which just gave her another level of trust and comfortability. And then psychosocial approaches, I did a little CBT, letting her choose some affirmations that she believed were true, doing that walk and talk, so just kind of conversation, connection, and then that's self-advocacy. We saw her once a week for an hour, and once we started that group, we split her hour between individual for 30 minutes and then 30 minutes with the other patient, as tolerated. And then these are evidence to support occupational therapy and mental health for children. And then her progress, this is how the goals were written in this clinic specifically, to be accomplished in 12 weeks with 80% accuracy in 4 out of 5 trials. So these were the two that I would say I focused on the most. Navigating a room crowded with furniture, people without bumping into anyone, advocating for herself for movement or needed items without dysregulation. So I watched her progressively be able to transition throughout the clinic independently without distress, navigating from room to room, and then also doing that walk outdoors where she was the one sort of deciding which direction we would go. And then patient will participate in fine motor dexterity and bilateral coordination tasks and maintain regulation during challenges with standby assist. I watched this progress where eventually she was able to tolerate sitting in a swing for 10 minutes without dysregulation, where initially she had an adverse reaction as soon as she sat in one. And then completing those fine motor art projects, including painting, drawing, and writing, showing her progress in fine motor coordination. Some home program and patient caregiver education that we provided is sending that email with recommended alerts to support her desire for community engagement, as well as taking her meds on time, creating that therapeutic tool for olfactory sensory input as needed, discussing advocacy. We drafted that email, and then making that daily schedule with an easy self-check list for self-care routines that she could have at home. And then she was still working with my CI when I left, so I did not see her discharge. Congrats, everyone. Way to go.